Dr. Alex Craven. How are you?
Good. Nice to see you. Thanks, Jackie. Thanks for having me.
Likewise, thank you. It's been a long time coming, so I'm really happy to pick your brains
I
for a
feel
little
like
while.
we've talked about this for about 2 years, and then that never actually happened. But yeah,
Life takes over and you're very busy. And yeah, obviously, both of us are going to be busy in June visiting the Future of Obesity and Metabolic Health event in Sydney, where you'll present. What are you talking about at the event?
they've sort of asked me to reframe, I guess, where we're at with obesity and metabolic health, a little bit about what we now understand about what really causes obesity and why that should probably change how we approach prevention. And then how obesity works, and we're learning a lot very rapidly about that, and how that might change our general approaches in the future. So it's kind of exciting for me. I do a lot of, face-to-face clinical work and practice and talking to people. This is more of a bigger themes and ideas type talk that I'm putting together. So it's been cool to look at it from that point of view.
Yeah, it is when you look at it like that. It opens it up, doesn't it? And you and I were saying how it's a great idea, but an unusual one that we have the representation from professional as well as the public. So it's nice to have it open for public audience to come and sort of learn about what's happening. And we're looking at destigmatizing and learning and just working with what is. And I guess with our environment and our lifestyles being the way they are, and obesity being certainly on the rise as a result, it's nice to kind of look at the seat of it, but also kind of where we're going. And it's always fascinating to me when we attend conference anyway, just to see the amount of research and what goes into helping and solving this massive puzzle. And yeah, I guess making a difference.
Yeah, and I think that the point that you made there about having the public, and I think particularly having people affected by obesity in the room, is incredibly important. And I'm yet to hear confirmation, but one of the things I've requested very strongly of the organisers is that we have people with lived experience, not just
Mm.
in the room as audience, but actually up front talking, because clinicians who are not directly working in this space on a day-to-day basis, and even if you are, I think we have a lot to learn from hearing the narratives and perspectives of people with that lived experience. And I've now run a few events where I've had people who have pre, post, during treatment, up on stage with us, speaking to clinicians, and the practical value, not just the kind of sort of, I guess, moral and philosophical value of knowing of hearing directly from the people that we're trying to help, but actually the practical tips that we get from people who have walked
Mm.
walked the walk is really invaluable. So I think that's going to be exciting, and I really hope that we do hear from people, real people and real stories, because I think that would really be the icing on the cake for what otherwise looks like a really good conference.
Yeah, I agree. Yeah, so I'm very much looking forward to that. You have a few presentations to make, and I'll be there doing some moderation and chairing some of the sessions. So I'm pretty excited about it,
You'll
and
have to
I
keep
think
me
it's
to time.
amazing.
That'll be a problem. Yeah.
Oh, yeah,
Sorry in
zip.
advance.
I'll have my little timer out. So, what I wanted to cover today is talking about this, I guess opening up the understanding of the future of obesity and I guess looking at different ways that we are exploring and gaining new insight into supporting people with obesity and identifying it early, I suppose, or preventing. We know that there's genetic factors involved. How much of that plays out, do you think?
Statistically speaking, we'd say 50 to 70% genetically influenced, and a majority of the remainder relates to the environment someone's in. But that does vary significantly from person to person. And then it gets very complex very quickly, because it's very easy to say, oh, it's genetic, environmental, but there's over 100 genes already that have been identified that play a role in the development of obesity. And some of those push a general trend towards obesity, and other ones it's more like a lock and key, where they infer a vulnerability to particular influences from the environment. And it's funny because science has finally caught up with what our patients have told us all along. I was fine until I
Isn't
had
that
that
good?
injury. I was fine until I had my first pregnancy. I was fine until X, Y, or Z. And then suddenly things changed. And I think there was this idea then when we see things develop late in life, we think, oh, well, this can't be genetic. But colon cancer is mostly genetic, and that doesn't develop for most people until their 50s, even if they have a strong, there's exceptions to that. But we're starting to get the idea that actually this is largely genetic. And then another whole field of research is how these genes get turned on and off, what we call epigenetics. And so the influence that things that are happening to the mother before she even gets pregnant, while a fetus is in the womb in the first 5 years of life, that change gene expression for life and have durable lasting effects. And that's a whole nother area. So you say, oh, it's genetic. Oh my gosh,
It's
that's
like,
just there's
needle
textbooks
in a
of
haystack.
yeah. And I think leading on from that, when we talk about the complexity, I think one of the exciting things is the growing realization, and a lot of us have been talking about this for a long time, but I think finally a lot of the world's catching on to the idea that when we say obesity, it's really like saying cancer. Yes, we can talk in the singular, but we're really talking about a huge variation in regards to genetics, in regards to the environment, in regards to what that's doing to the human body. And we get so caught up in weight and body measures and sort of can sometimes miss that. So it's sort of like saying, I remember back in the 80s, everyone was going to cure cancer. And I'm sure the oncologists were thinking, which one though? Don't they know there's more than one cancer? And it's sort of the same now with obesity. We're realizing, yeah, we're going to fix obesity. We're like, well, which one? Because there's a myriad of different variations here that affect people very differently. And that's what makes it so exciting. It's really, I get, yes, I love doing what I do. And a big part of that is that really, I get to drill down on what's the actual scenario we're dealing with here and how can we best help the person with that. And it becomes exciting, it becomes interesting.
And I think that's great that we're getting to that. Is like we used to just treat symptoms. So patient would go to the doctor, your blood pressure's high, let's treat that. They were sort of compartmentalizing this metabolic picture and kind of managing little bits of it rather than like you are getting to the seat of what is actually going on. Was it one, incident that's triggered a whole cascade of different changes in the body and then looking at where to begin?
Yeah, and I think I think that was often recognized, but almost with an air of despair, like, oh, this is all probably driven by obesity, but nothing really works. And I talk about, I'm not sure how careful I need to be about language, but I talk about this crap care cycle that a lot of patients and clinicians have been engaged in for a long time, where this kind of non-scientific idea that obesity is a choice or a lifestyle issue, and if we just try harder and eat less and move more, patients should get better. And I honestly came out of medical school thinking I knew in my heart I understood obesity. I can talk a bit, I can have a bit of a silver tongue, I'm very good at motivating people. I was going to fix this. I just had to motivate people better. And it was the same sort of messages trumped up with a medical degree behind them. And so when you approach obesity like that, you get predictable results. People get about 1%, 1 to 5%, total weight loss from self-directed therapy, about another 1 to 5 if they're having, a really good engagement with a allied health practitioner to help them. And then you're setting them goals like make your diabetes go away, which we know is going to need at least 15 to 20% total weight loss. So you're arming them with completely insufficient tools, and then you're giving them ridiculous goals, and they don't get anywhere. And of course, it can't possibly be me, Dr. Alex. I know everything about everything. And and so you sort of get this situation where I've got to look then really hard at my own ego and whether maybe I've got it wrong and my advice was a bit rubbish, or I can blame it on my patient, or we can both agree that it's just too hard and there's nothing we can do. And whichever way we look at it, that's a miserable experience.
Yeah.
And
You
it's
can see
kind of
how people
hard.
do that.
Why would you want to specialize in that? Why would you want to do that? Like, oh my gosh, that like you just revolving door. You either come to the realization that you're not good at this, or you decide that your patients aren't good at this. And again, the importance of having people with lived experience in the room is evidence didn't change my mind on that. The studies that showed those numbers that I gave you had been around for decades before I came out of medical school. Meanwhile, the studies that showed the impact of true obesity treatment, like that with metabolic or bariatric surgery, had been around for a similar amount of time. There were guidelines, there were pathways, people were screaming to the world, no, you've got this wrong. But because then, and I even think now, you're coming through medical school, you're living in an environment with a specific mythology around obesity, you're caught in that and you can't get out of it. And what does get you out is sitting down and actually hearing real people who are kind of like you, except with a different genetic hand, telling you what's really going on for them. And that was the experience for me. I ended up in a public hospital bariatric surgery clinic where I still work and will endeavor to work till they have to drag me out in a box,
I see that.
where I had to sit down and actually think to myself, hold on, there's something going on here. This isn't a lazy person. They are manifestly motivated, intelligent, dedicated, doing stuff, working hours that I don't. And I'm a surgical registrar, so I'm like to the grindstone. These are not greedy people. These are not people that are, in fact, they are trying so much harder to control their diet than I ever have in my life. And so you sort of have to start then re-examining that framework. But I think until you actually hear real stories from real people, you're not going to look back at the evidence. And particularly if you're a clinician in today's world with, we were just talking before this about all those papers that come across your desk every day. And you're like, oh my gosh, I've got 10 papers I want to read and I might get through 3. And it goes on and on and on. You're not going to deliberately look for the stuff you don't understand. I'm not going to look for stuff about orthopedic surgery because that's not my wheelhouse. And so you're not going to look for that until, there are areas I'm sure that I am not good at in medicine, but I just don't know it because I don't know it. So you don't know what you don't know until you sit down with a patient that sometimes with a real blow to the ego shows you that you're really barking up the wrong tree. And I think that's the power going forward. And I'm hoping that more of my patients and more of other people's patients are ready to tell their stories and bring clinicians on board. We're certainly getting it. There's a real sort of groundswell of enthusiasm, and there's now an RAC GP special interest group with thousands of GPs that are like, we want to treat this. We're interested in this. We're excited about this. And the same goes for all the other allied health disciplines. And I think talking to the metabolic surgeons that are close to retirement that have been doing this for a long time, they were the only ones in the room for a long time. They were the only ones that said, no, you need a dietitian and psychologist involved if you want to do this right. You need to have good partnership with your GPs if you want to do this right. And, we tried just doing surgery and kicking people to the curb and it didn't work. And that's kind of what these online, medication farms look like. It's probably not going to be great in the long term. We've been here before. And so all of those conversations are happening, and it's cool. It's cool.
It is good. And I think that's part of the uptick in the GLP-1 and the medication route for weight loss, is that, good or bad, it's starting the conversation and it's helping people to access or to start the conversation with their GP or doctor. But I do feel that you're right, without that specialist umbrella of someone who really understands what they're dealing with, I wonder where we will be in 10 years' time when we've had these, online purchases of these products and no support and that kind of ongoing benefit, because we know that these medications are helpful, but without that kind of holistic approach and that team that a bariatric patient would get. Where do you see that heading as far as outcomes go long term?
Yeah, look, who knows? I think I agree with you that I mean, we've been crying out in metabolic bariatric surgery for good combination therapy and good medical therapy for decades, and it's great. I think that some of the more popular agents at the moment are moderately powered. They're not particularly, they're not super effective. And in that circumstance, that there's a lot of talk about the potential for nutritional harm. I think with the less effective agents, I'm not so worried about that. We know people that are having 5 to 8% weight loss, unless they've got pre-existing nutritional issues or significant diet issues. I don't think we need to be alarmist about those. I think the newer agents that are more effective coming through, what we've seen across the board in anything from anorexia nervosa to metabolic and bariatric surgery is the percentage of total weight lost correlates pretty well to nutritional risk. And so, now we've got some medications around that are about half as effective as metabolic and bariatric surgery. So potentially about half the nutritional risk, which is not super high, but it's substantial. Now, the difference with metabolic and bariatric surgery is in most cases in Australia, it's a bit different if you're running off overseas and sort of, having a sleeve as part of your vacation. But most practices are linked in with community support, have follow-up programs. Most, in our practice, both public and private, it's an open door policy for life. We want people coming back all the time for life. Everyone gets nutritional and psychological assessment before. Everyone gets that, wraparound care as they need it. We don't, not everyone needs everything, but it's all there. We don't see much in the way of nutritional harm from metabolic and bariatric surgery, despite it being highly effective. And I'm now starting to see surprisingly large numbers of patients with nutritional deficiencies for less effective treatments, and which I think is almost always preventable. So, you don't want to be alarmist about it, but I think it is the medications are delivered at such a higher scale than metabolic and bariatric surgery ever will be, that I think even if the risk is low, the numbers will be high.
That's a good point.
And I think there's a lack of awareness at the moment. But it was kind of the same with metabolic and bariatric surgery. When these things are tested, they're tested in an environment with the sort of support, drug trials are bloody expensive to run because all of these people are gathered around. Patients being seen once a week or once a fortnight, and everyone's there and everyone's checking and bloods are done and all this sort of stuff. And that doesn't always translate to the real world. And I think in nowhere in obesity so far have we got good effect without, a small but significant risk of nutrition. And so that's going to be a thing. I think that's going to be both more important than some of us inspect, and probably less important than some, crazy news articles are going to suggest it's going to be, but it's going to be a real thing.
It'll be there. It'd be nice to see we're as being a part of the support for that aspect of metabolic and bariatric surgery, the nutritional aspect of it. It's interesting to us to see long-term kind of where the nutritional deficiencies lie within a medical weight loss patient. We know bariatric surgery back to front, and we can predict that. But we're seeing evidence of like a 64% reduction in caloric intake time and time and time again. So there will be gaps, but we just don't know if they're just a broad brush of gaps or whether there'll be specific nutrients that are affected. So we're very much interested in seeing that.
You made a really good point there about the reduction in caloric intake.
Huge.
And the reduction in food intake. And I think there's this idea out there that in metabolic and bariatric surgery, it's because the stomach's smaller, so it's not as absorbing, and the bowels, skip, so it's not as. Actually, very, very few people have true what we would call restriction on their eating, and very, very few people for good metabolic surgery have malabsorption. And in fact, if people do have malabsorption, we could try and go and fix it. It's not a thing we're aiming for. Actually, time and it is clear that the degree of nutritional risk relates to the degree of reduction in food intake. And so the more you reduce food intake, the more you need to watch and be careful of that. And that's true of restrictive eating disorders as much as it's true of medications, as much as it's true of surgery, which is kind of cool, because when you kind of frame it that way, a lot of dietitians are like, I just got to think about this as someone that's lost 10% through a restrictive eating disorder. Okay, well, we'd better check this.
I know what to do.
And the kind of eat less, move more goes to the side. Well, you step in and do what you do. So
I guess so too. The bariatric patient is much more monitored. So we know that a patient has surgery, they have their bloods checked, they take their supplements, we monitor, and it's a goal that we do that for the rest of their lives and that they supplement. But these other groups are just left free rein in a lot of ways. I don't know if the GP would be specifically looking for nutritional deficiency unless they walk in and they're falling over.
I would say that we we have a lot of GPs that really have become specialist metabolic health practitioners or
Yeah, it's
specialist
great.
nutrition practitioners or whatever. They are not going to miss any of this. You know, that they're in this world. I'm much more concerned about sort of online telehealth approaches or without a follow-up and that sort of thing. I think those practices, and you can usually tell them, they've usually got an in-house dietitian and psychologist or work very close with them, usually an exercise physiologist in the mix as well. You can really pick the practice like from the door.
Yeah.
I think I've got no concerns of anyone into those practices. And I'm not saying that, you know, that means every other practice is bad, but also, you know, patients will soon get an understanding that they sit down with someone and the conversation is not about how much you eat, but whether you're being nourished. You know, the conversation is not about eating as little possible, but making sure that you get satiety and you know, and aren't forced into snacking between. You sort of see the conversation about regularity of eating and adequacy eating and variety of food and all of those
100%.
sorts of things. And suddenly, you know, I'm in a place where if it's just this a transactional relationship, then I think that's a worry.
Yeah.
I think also what my prediction is, you want my prediction on the nutritional issues, it will be exactly the same as we've seen in bariatric surgery. 2 peaks. One, after initial rapid weight loss phase, and 2, about 3 to 5 years later. And the reason I say that is that, again, I think these are often seen as weight loss drugs or appetite suppressing drugs, which is actually a poor way to describe them. That's not really how they work.
Not magic pills?
Well, it feels like magic, but it's actually just biology.
Yeah.
And they work in very much the same way as good metabolic or bariatric surgery, in that from a weight point of view, so 2 things. One, they do a lot of stuff that has nothing to do with weight. You know, metabolic surgery has a dose-dependent effect on keeping people alive, extending their life. It works on reversal of, you know, fatty liver disease and all these sorts of things. And it does a lot of that stuff, even if patients don't lose much weight.
Yes.
And these medications as well in the studies have shown a dose-dependent effect on kidney health in those that have kidney problems, and heart health in those that have heart problems, and liver health in people that have metabolic associated liver disease. And so they do all of that stuff. So much as you might take an aspirin to look after your heart, or you know, if your cholesterol's up and you're worried about having a heart attack, then taking cholesterol medications until your cholesterol's normal and then stopping them is not going to protect your heart. And so one, you know, if this is these are medications to treat the disease of obesity. This is surgery that treats the disease of obesity.
Yes.
And so they're there to do that.
Yeah.
In a weight sense, is a separate thing. What I would say is they really act as set point reducing medications and set point reducing surgery. And I don't really like the term set point, because I don't think we're talking about a single weight. There's a range, and that range goes up and down over time. So women will have a range that varies along with their menstrual cycle, often up during pregnancy, down, you know, all those sorts of things. So it's a bit of a range. Like the body will accept, you know, if you weigh yourself every day, you'll weigh a little bit less or more every day and every week and so on. So it's more of a range than a point, but you get what I'm talking about. And that in, you know, normal from when we get to adult size until about our 70s is for that to go up gradually over time. And then sort of in our later age, it tends to stop going up. What these medications, and this is the point that the body fights for. So if we caloric restrict below that, we deliberately do that, the body makes us hungry, chase food, think about food all the time, all the food noise stuff we talk about. And we need more to feel full, and then that fullness lasts less time, and et cetera, et cetera. That's the body's way of saying, hey, I weigh less than I need to, and I want to be up there. Much as when your oxygen levels drop, or more important, your CO2 levels get higher, you're going to breathe harder. You can hold your breath as long as you like now. At some stage, your body's going to make you breathe harder, to the point where it will put you on the floor unconscious, so it can start the breathing for you because it doesn't trust you anymore. And so the same is true. It's just as powerful with weight. It just takes a lot longer, and we're kind of not as aware of it. Also, energy usage will shut down. Not a heap, but just enough. that it'll be ready to jump on any calorie that you put in. So that's what the body's going to do. And then we put these medications or surgery into the mix, and that set point is reduced.
Mm.
So for a while, the body is detecting itself as heavier than it wants to be. Hunger goes away, appetite goes away, satiety and satiation come earlier and last longer. We stop thinking about food, and people that have been calorie restricting for a long time, this is revolutionary
Game
for
changer.
them. It's like,
Yeah.
oh my gosh, I can think
Yeah,
straight.
I can think about anything else.
But there will be a point at which that weight will drop to the new set point, set range, whatever you want to call it. And some normality will return. Now, most patients will tell me it's not, the hunger is not the same as it was. And the food noise is not the same, but it will come back. Some of the weight will come back on. And then most people will return to baseline weight trajectory, that 1% to 2% per year going forward, because that's what normal human bodies do. And so if that's explained, then the patient understands that I'm going to have this phase where all the food noise is going to go completely absent and weight's going to pour off without me even trying. And I'm really going to have to be careful to make sure that, I'm getting what I need from a nutritional point of view, adequate protein, proper amount of plants in my diet, all that sort of stuff. And I might need to take a multivitamin if I'm really eating less and all that sort of stuff. But then at that point, the weight's going to even out. So if you tell patients this is a weight loss drug, in their mind, they think, oh, this has stopped working because I've stopped losing weight. If you tell patients this is an appetite suppressing drug and their appetite comes back because they're caloric restricting to try and keep losing weight when their set points are low, then they're thinking, oh, well, this is an appetite suppression. The appetite suppression is not working. And most have a little rebound, not much, but a little bit of rebound at some point as well. And so now you've got a patient that you've set up for stopping this medication that has a dose dependent effect on keeping their health better. And so I think this is a real problem, the way we describe these medications. The other thing then that happens is a patient stays on that medication if they are smart, they're well informed enough and looked after enough that they understand this is a medication you need to take for the rest of your life if it's going to work. If you stop that medication, the set point goes back where it was, you go back to where you started, not just from a weight point of view, but generally also from a health point of view. If they're staying on it, it's still working and it's still doing the things. And so the nutritional risk doesn't go away. And so again, often, weight's been stable for 2 years, and this is a classic, I need to go home and relax. So often it's sort of, the multivitamins get forgotten, or it's just sort of, I'll just pick up something random off the shelf and see how I go, and maybe add a bit of, some weird concoction for hair, skin, and nails or something like that. And then suddenly, we're like, oh, okay, your B6 toxic and your iron's in your boots and vitamin D's a thing. And so
it is about that 3-year mark. We see that it's the stored nutrients.
It's been well documented
isn't it?
in metabolic surgery we just haven't looked long enough yet at the medications will be exactly the same because that's what happens. And I think, again, I suspect that's not going to happen in those wraparound. It's very rare in metabolic and bariatric surgery clinics because you're calling patients,
it's monitored.
Back in, you're doing their bloods, you're doing you've got your yearly appointment.
This is out there, it's free reign almost, isn't it?
Yeah, but when we do see it a lot is in travel, surgical tourism. So, fly off somewhere to some country and get a sleeve done and kick to the curb. And we do see it in unfortunately, we do see it in some practices in Australia that don't have that wraparound care. But in the vast majority of established
it's
metabolic
certainly come along so far.
It's a standard, it's a non-negotiable standard. It's not okay to discharge your patient 2 weeks after surgery, never see them again. It's not okay to have, a lack of lifelong follow-up. That's just not, that's not right. That's not good standard practice for the chronic disease of obesity.
We talked a lot about that ongoing long-term. And it must be, from your perspective as a practitioner, it must be quite amazing to see some of the the transformation and the lifelong benefit of what you're doing. It's quite amazing when you see
fantastic.
people.
I get really grumpy actually on. I get really a lot of the stuff you see and I don't mind this coming from patients, but it drives me nuts when practices just show before and after photos, and there's the lycra and the belly out and all that sort of
Yeah.
stuff. And it annoys me because it really feeds into that missing the point about what good
What
obesity
actually
treatment
else has
is.
happened?
But why it really annoys me is I'm like, why aren't you telling the stories? Like why aren't you telling the stories? What, oh man, people have been through 3 rounds of IVF and given up on having a baby and then just have one.
Yeah.
And not only that, now can get down on the floor and get back up again to play with that baby in a way they couldn't do before. Tell us that freaking story. Don't show me some stupid belly out photo. Give me that. That's the story. The person, this wonderful lady that was like into karate forever. I'm getting emotional now just thinking of it. And she's back working up through her karate belts
With the
again.
belts.
And I just see these occasional photos of her kicking ass. And like,
And it
tell
is, it
those stories,
sidelines you. These people are on the sidelines for so long trying to work out what to do with it. And quite a lot are specifically very active beforehand. And then you say that something happens and something changes. And they're like, whoa, what happened there? And then once we work it out and support them and, and we see it, they come in to pick up their multis and they're getting ready for surgery. And then they come back and we just, hardly recognize them and hear the stories. And I think it's part of the work. It keeps you kind of tuned into what's
so
possible.
cool. Yeah. I'm like, don't show me your shrinking waistline. Show me your shrinking list of medications. Show me your shrinking list of activities you can't participate in. Like that's where it's like, it's just, it's so great. That's in the private system. We have our own patients and poor buggers. I'm with them for life. They're stuck with me for life kind of thing. Whereas within the public, all across the surgeon, that sort of thing. So we don't get that same contact the same way. But yeah, that's just one of the most wonderful things about working in the private system is you just get to follow that through and see the massive functional wins. And often you hear about stuff, some of it's stuff that people are too embarrassed to talk about before surgery that goes away, and it just breaks your heart. You're like, that was a real problem for you and you couldn't talk to anyone about that because you knew that you would just get this shaming, blaming type conversation about a really fixable problem. Like that's pretty, that's the flip side is it's pretty brutal when you see people that have been neglected
what they've experienced in
decades.
that. And they're saying there's like 8 years before people will struggle with their weight and feel that they can't control their weight for 8 years before they reach out to say, I don't know what to do here. They'll restrict calories and try every diet. And then that 8-year mark, and it's to do with stigma and shame of I can't fix this myself, and it's not often a fixable thing on your own. So it's that awareness that we're bringing with advocacy and awareness of kind of the life that goes with this is also something that's great to uncover.
Yeah, I agree, and it's I think that's another reason why we need to hear directly from people with lived experience, because a lot of people have been through all of that, and when you talk to them their experiences, then when they finally reach out for help, the first thing, have you looked at your diet? Have you tried more exercise? You kidding me? Like, that's your experience.
Like,
and that
they're
then
expert
can just
in calories and exercise.
And people aren't silly. They know they're not getting anything for extra to what they've already tried from that conversation. And then it sort of loses that trust, and it's another year or two before they build up the courage. And the tipping point for most patients, well, I don't know about most, that's not fair, but some of the people that I listen to from the lived experience world, the tipping point really is that non-stigmatized, that approach of like, okay, what are the challenges for you, and how can we do that? And it sounds new and interesting and different in obesity, but the reality is it's just normal medical practice. If you come to me with an esophageal cancer, we sit down, I find out all about you, and we find out as much as we can about the disease, what it's affecting, where it is, how far it's spread, all the rest of it. we take some biopsies of it, and then try and interrogate the biology of it, which we kind of don't really do yet with obesity, but we're going to soon. And then we come up with a plan. And then that initial discussion, we talk about all the options. There's medications, there's radiation, there's surgery, there's involving a dietitian and a psychologist, and not that everyone needs all that. Absolutely not. But it's all there and it's all on the table, and it's a matter of matching what's needed to that patient. That's incredibly rewarding medicine for the patient to receive and for the practitioner to provide. And I think we're so stuck in this, as I said, this sort of care cycle of based on mythology that we don't get a chance. And when you do, like, I particularly, in the public, I get every year there's a new set of interns showing me how old I am. There's a new set of registrars showing me how out of touch I am with popular culture. And it's one of the most rewarding parts of that is that you then reframe this whole thing, and surgeons and doctors love solving problems. I mean, if you reframe this as a solvable problem with a range of tools, yeah, and they're in it and they're excited and they're great. One of the best talks I had recently when I talked all about the basics of this to an ICU team, and the questions are flying, and you can see that minds are actually changing, which is rare and wonderful.
It is good. And I think I did a podcast with Nadia Walton recently. She's a physiotherapist. I'm sure you know her well. And
she and I are working on an event at the moment,
Mm.
and I sat down with her yesterday, and poor thing, we talked each other's ears off. It was great. Yeah.
But just like what we unpacked there was that 2/3 of the population are struggling with living in a larger body, but the healthcare system is made for someone who's, regular size. And then how are we doing that? And how can we, and things are moving quickly technologically, but we're still moving a little bit slowly on the uptake.
Yeah.
And change in a system is difficult.
I'm gonna go one step further than that and say that most of the healthcare system is actually deliberately engineered towards people who are undersized. So
Yeah.
we have worked very hard in healthcare in general on, we have an aging population, and falls and injuries from falls in people of advanced age are a real thing and a real problem. And that's great. But that probably represents about 10, maybe 20% of our hospital population. But you walk around, and next time you go to hospital, have a look at how many of the chairs are very narrow with really narrow armrests. That's so
And
that
the arms are
if you
high.
are frail, you can push down and get yourself out of a chair. And the same goes for beds, bed rails, toilets, and all the rest of it. And narrow framing again to help people get in and out. And I think that's excellent and the right thing and important for health and safety.
Yeah.
But we also have 30% of our hospital, actually it's a little bit over, it's probably closer to 40% of our hospital population with obesity, and at least 10+% of those with what we would term severe obesity, either based on clinical effect or on BMI class.
Yeah.
And so we have we have the same number of people affected by these issues as we have affected by age and frailty. Yet on the one hand, we have completely overhauled our hospitals, and on the other, it's I have situations where and hey, we're one of the good ones. I'm not labeling any of that we're actually trying to fix this. Most hospitals are kind of trying to ignore this. We've had hospitals that have deliberately downgraded the weight of the patients they will accept, despite the fact that severe obesity is the largest growing obesity group in Australia at the moment in terms of numbers. So we're one of the good ones, and I will have issues where I literally don't have somewhere for someone to sit, so they'll be perching on the edge of something. Standing in waiting rooms, and public hospital waiting rooms,
you're there
they
for
have
a
the
while.
waiting room there for a reason. You are going to wait, and the real one that hits me every time is situations where patients' families know they won't really be able to visit because they won't have anywhere safe or comfortable to sit. So, this, it didn't occur to me until I had this lovely lady who she looks after kids that have come out of juvenile detention, like angel on earth type lady, and it hit me with that. Oh my gosh, your family, yeah, they're not going to visit you because where are they going to stand? And where, they're going to drop in this. They can't just sit by your bedside. So that, yeah, those sorts of things, and in a way that we wouldn't accept with any other segment of our population, in a way that we would be embarrassed and disgusted by if we were healthcare services and there was any other aspect of someone's physical appearance or shape or size or whatever that we would refuse to at least try to accommodate. That would be shameful, and Nadia's right. And the flip side of that is we have people like Nadia, who we're hoping to work with very closely at the Austin to work on this. There are passionate people really trying to change that, and this isn't about making those bodies smaller or treating obesity or anything like that. This is just basic.
This is recognition, isn't it? And
yeah,
exactly. I wanted to go back to something you said yesterday, and it really struck me as a great, I guess not a rule to run your life by, but it was like we were talking about eat less and move more. Like patients turn up, they're struggling with their weight, they go to the doctor. The doctor's like, yeah, have you tried eat less and move more? And you said eat less and move more is more of a goal rather than a technique. And I thought that was quite powerful in that we've got this goal of helping these people to eat less and move more. It's not sending them off to do it by themselves. It really stuck with me.
Yeah, so first thing, not mine, stolen from some guy on the internet somewhere, and I was just like, yes, this is the thing. But I'd been sort of trying to phrase this concept for a while, and I think a lot of us talk this way. And so if you sit down and have a medical conversation with someone about what they're chasing, one of the first things I do is sit down and clarify with my patients what are goals, what does success look like, and I think that is probably the most important conversation I can ask in any consultation. You otherwise, what's the point?
What does the patient want? What is their why? So that they can go back to that why when things are tricky. Things are not easy. It's not a straight line to where you're headed. So I think coming back to that, and I think I see that a lot more, is that patient-centered care of like, what is your idea of success rather than a number or something that we think would be successful.
Because I think otherwise too, you can get trapped into not great care. Yeah. Like it's very easy for me to show you all the numbers that show that metabolic or bariatric surgery is the most effective treatment for obesity. It's the only thing that has a real significant and sustained effect on how long people live and how many people die. The medications are great, but the one thing we're missing, the key to the puzzle that we haven't seen from them yet, is actually less people dying. And I think we will when we watch long enough. But certainly they're not going to do that to the same extent. So I can show you all these wonderful charts and all this sort of stuff about this is the thing that's going to keep you alive the longest and decrease your chance of death the least. And that's worth remembering. It's obesity does kill people. In fact, I think now we've finally got to the point where it kills more people than even tobacco smoking. It's certainly the highest burden of liver disease. So I think often it's like, do the safest thing first. Well, it's kind of like standing in the middle of a highway. The safest thing is to get off the highway. Standing still is kind of second best, but really, yes, you might trip if you take, one step in either direction, but really you want to get off the highway. Now that's not everyone. Not everyone has life-threatening disease of obesity, but if people have a disease caused by obesity, what we would call stage 2 obesity, then they're, mortality is significantly increased. We have no doubt about that. And so not doing the effective things is bad medicine. So very easy for me to do all of that and say all of that. But this is a lifelong chronic disease. And there are a number of approaches we can have. We can step up, step down. We can look at combination therapy. We can do all those sorts of things. And so to just throw out, well, this is the most effective thing, let's go, is not always going to be the best thing. And it's certainly not a good part of making sure the patient's informed in what they choose. And so we really want to look at that and what they're out to achieve. Some of the things that people may be out to achieve may be achievable with diets or medications or surgery. Some of them may only be achievable with, realistically with medications or surgery, and some of them will only be achievable with surgery. But if you don't know what you're aiming for, then you're not really going to know. The other thing too is that point I made, this is set point reducing therapy. We're going to get to a new set point and we're going to stop. And at that point, if we're looking at weight, if we're looking at a number on a scale, then we've kind of got one measure of success and nothing else. And in everything we've done for obesity, there's enormous variation in what a normal response is. What is much more useful for me and my patients is to actually find out, what are the things you want to do? What are the things you want to go away? Sit down and have an honest and frank conversation about which of those will respond to which therapies, and then choose a way forward. And then reassess, when we hit that point a year or two later, we think, did we achieve our treatment goals? And there was sort of, for the longest time in metabolic bariatric surgery, we didn't achieve our treatment goals, and, we can add about 1 to 5% from some really strict diet stuff, but that's probably not going to get us there. Now we have this wonderful range of medications that we add on top. Not only that, most of them are better tolerated and more effective after surgery than they were before surgery. So now we've suddenly got this thing that we can sit down and reassess and say, right, not only can I just be your surgeon, but I can actually sit down with you and we can make a lifelong strategy plan and work around specific circumstances.
That makes sense.
But I guess with all of that, with the goals, what comes up again and again and again and again is something around moving more. That's what people want to do. Funnily enough, when your body hurts or is really heavy or doesn't bend in certain ways, it's hard to move more. And so the answer of move more so your body gets smaller is not working. Move
not
more
on the
to treat
table
obesity.
sometimes, is it?
No, and whereas treating the obesity often results in, with no sort of effort, results in more activity. I really don't talk to my patients much at all about any aerobic fitness type stuff. All we talk about is resistance training, because that has a little bit of a higher threshold for engagement. You need to sort of have some heavy things to lift and know how to do it safely and know how to program that and all that sort of stuff. So we talk about that. But I know that all of my patients, the steps on the pedometer go up, the amount of, time spent in moderate intensity exercise just goes up. You just have to ask them how they're doing at 6 weeks, and they'll talk to you about all the extra stuff they're doing. And so it's not, and I'm not having a go at exercise. Exercise is very good for you. Exercise is as close as we have to magic for cardiometabolic disease, no doubt about it. But it doesn't treat obesity. And if obesity is getting in the way of exercise, then you've got you've got a vicious cycle. Whereas if you can improve the obesity, control the obesity better, then the exercise comes along, then you're taking, 2 steps forward instead of 1. And so that's sort of what I mean is, and it's the same with the eating side of things, is that when it comes to caloric restriction, for a large group of the people, that is health promoting. Eating a reduced total body caloric intake does promote health. So does eating plenty of plants. Again, closest thing we've got to magic for cardiometabolic health is eat a bunch of plants. And then you want adequate protein intake. It doesn't have to be crazy. I think we get really excited about protein these days. I don't think the evidence supports as much protein as possible. It supports adequate amounts of protein, and a lot of plants would be really good. Magic for cardiometabolic health, but doesn't really treat obesity well at all. 1 to 5% weight loss, and if you end up, and that's got to be a sustainable diet as well. And so a lot of people end up on sustainable caloric restriction diets, but that aren't doing those things. So you end up like, okay, I've lost weight successfully on this diet, but often it's a diet that objectively is not really good for you. If we look at those rules of, are you getting enough vegetables? Are you getting adequate protein? And are you, and have you shifted from sort of animal-based to plant-based fats? Whereas when we treat obesity and caloric intake is coming down, then suddenly you can have a sustainable diet that does do those things as well. And so again, one of the GPs talked to me about the O&C diet. I was like, what's that? He said, Ozempic and chips. I was like, I see your problem. But so if, you're throwing something out there and just eat as little as possible, there's a difference
Yeah, the
between that and
same
saying,
things
I'm
that
going
you were
to
doing
treat
before.
obesity with something that I know is going to reduce your caloric intake, and then let's couple, and now suddenly it becomes sustainable to also have, you can have that health promoting diet in a sustainable fashion that still meets your obesity treatment goals. Again, two steps forward instead of one forward and one backwards. And so, yeah, that's, when we ask people, are they moving more or eating less? That's, and if they're not, by the way, that's my problem. That's for me to deal with. That's the other thing
But we
too.
also know that incidental activity is a bit more of a contribution to our overall metabolic health or our weight management than just one bout at the gym. And I think we put a little bit too much emphasis on these short, sharp bouts of exercise as opposed to how obesogenic our lifestyles have become, where everything's so easy. It's remote control. We sit at our desks a lot. It's like, simple things of getting off the bus one stop earlier, which sounds, like a nice thing to do, or taking the stairs. But we know that that kind of activity is actually a good contribution to that everyday wellness and I guess weight management rather than, but both have their place. And I'm a big believer in having more muscle on your frame for, keeping your metabolic health tuned in.
And I don't say this as an exercise professional, but more from a medical, keeping people alive and keeping people functional point of view. Again, the more you look at it, the more complex it gets. But I think we now know they're all important in independent but synergistic ways. So sufficient stimulus of your muscles to maintain your muscle bulk is really good. But doing that to the exclusion of any other exercise, you're leaving a tool back in the toolbox. Equally, sedentation is harmful. So reducing sedentation is a really good thing to do. Also, maintenance of cardiopulmonary fitness, VO2 max and all that sort of stuff is independently and synergistically all the other things a good thing to do. And oftentimes there's very few people, I think, that are not addressing at least one of those. And I think we all sort of max out on the stuff we're good at. Like I'm the classic bloke where I'm like, I will go and lift some weights, but go for a walk. My wife just got me into park run and all things. She just had about drag me down by the ear to get the first one. It was really fun and I'm really enjoying it. But we tend to do the stuff that's in our own wheelhouse. And some people are really good at reducing sedentation. I'm lucky as a surgeon, a lot of my work is done standing up and walking around. And so I'm kind of lucky from that point of view. Others are not so lucky. And I think that two aspects is one, for some of us, it's harder than others. Two is, it's about filling in the gaps we're missing rather than maxing out on one or the other. And I think this is where I have a bit of trouble with some fitness industry professionals, because they will tell you this thing, high intensity thing, you got to do high intensity training, and there's a role in that, and there's a place for that. No problem. And like, you got to stay strong. Yes, role in that, place for that, but not everyone's going to get the same benefit from that. So I think that, and again, it's that personalized approach when you sit down, like
what do you want to do
for you, and a really good exercise physiologist is great for that, and then sort of program that in a sustainable way. And I think often we forget that, a lot of people are very privileged in what they can do that way. As I said, sedentation avoidance is kind of okay for me. I spend a lot of time operating, standing up and, rocking back and forth from foot to foot and all that sort of stuff. But if you're a long haul truck driver that needs to feed their family, there are some choices.
Or a night shift. We see that obesity affects a certain group as well. And you look at lifestyle or life factors, shift workers, truck drivers, nurses, teachers, those sorts of things. We see a lot of that in our audience. Do you feel that is how do you feel that impacts overall outcomes?
Well, the first thing I say is it kind of, I get annoyed when the reality of that is ignored. You know, this idea that you're lazy. I could not be a long haul truck driver.
Not in
No
100
way.
years, no way.
I can probably show you 100 objects in this room that I have because of a long haul truck driver,
Yes.
and 1,000 more in the house.
Yeah.
And this is just one. I'm not picking on long haul truck drivers.
Yeah.
There's a reality of what they need to do that makes my life better day after day. And this idea that then instead of, you know, and it's every other industry you've already mentioned that we all benefit from, that drives our economy, that gives us the lifestyle that we are so lucky in Australia to have. And yet we still want to cling to this idea of personal blame and shame. That annoys me. You know, these are not bad individuals being lazy or greedy. These are people feeding their family. I feed my family one way, and I'm lucky enough that keeps me on my feet a lot of the time. A lot of people feed their family in other ways.
Yeah.
And a lot of people, you know, like how, you know, an affordable gym with accessible childcare for a mother of multiple young children. That's like raising kids is freaking hard. Like I say that as someone whose wife really did bear the brunt of it. You know, there's all these sorts of things that we just...
It's the juggle, I think, these days of living in our environment, living with our financial pressures, all those sorts of things come into the mix. And I think that's where this patient-centered care comes from. It's like, where are you at? What resources do you have? What do you enjoy? What are your goals? How do we get to include these things with the resources and the tendencies that you have? And then the next person will walk in the door and that could be completely different. But
100%.
that's where the holistic care comes in, is you'll see it from your point of view and you'll know how to speak to it. And then the exercise physiologist will be able to weave in something. And I think that's where I ram home this, go back to your professionals, go back. The minute you have something that's unusual or not working anymore, or you're not sure, don't try and nut it out on Facebook or just drive yourself crazy with trying to find the solution, because that's what the professionals are here for. And that one session with, even with therapy, sometimes you turn up and it's like, oh, I don't have anything to talk about. And then boom, it'll be that one that you just go, oh, okay, I did not see that coming. So we don't know what we don't know. And it's like, you can take your situation to someone who's got that kind of broad view and that understanding and the seeing of so many different situations and different people's lives, that you can go, have you thought of this? Or I can see that that might be the thing. And we all have blind spots. And I think that's the beauty of this new way of working with a holistic team is, surgeon's done the job, has told me what to do here, but I've still got this part over here that's not working. And in that team, there'll be someone who can plug that gap. And I think that's where we're headed. And I think with the bariatric care, it's brilliant. I don't know about the medical weight loss, whether that will come and be, we need more centres that have that broad approach. And if this thing is going to blow up like they say it is, we need the clinics to blow up at the same time and turn up like milk bars on every corner, in my opinion, just to ensure. Wouldn't it be good?
I mean, in my the idealist in me is like, you know, I work at the Austin just nearby here, and we've got the Olivia Newton-John Cancer Centre next door, and I would just like the obesity centre next door to that. There's probably not enough room there, but there'd be plenty of room down at our repatriation hospital campus for the you know, whoever wants to name it. Man, we'll make this happen.
Yeah, you have to start lobbying.
And that is, you know, that's ideally what I, you know, gosh, if we you know, this is killing a lot of people, and in Australia we're really doing a terrible job of managing it, and you know, by local and by international standards, and particularly in our, you know, the government funded hospitals that are supposed to kind of be the real setters of standards in our healthcare system are really the least contributors. They're really dropping the ball more than any other. But yeah, the ideal idealist in me as well. Every place that currently has a cancer center next door also has an obesity center next door, and again, I think is naturally going to evolve that way. We're going to start to get some precision around knowing who's going to respond to what therapy at some stage.
Yeah.
The medications that we're looking at the moment, in a nutshell, are designed to imitate the effects of metabolic surgery, and so but kind of pick one hormonal signal at a time. When I think that last count I found about 18 or maybe 23, different hormonal signals from metabolic bariatric surgery that appear to be beneficial, for the treatment of obesity, and it's sort of like a polypill. But then within that, we're learning that, well, it's not all the hormones to all the people all the time. Some people are going to be particularly, and we've seen that with the medications. We'll try one and people really have a lackluster or minimal response, and then another one they'll really get profound impact from. And likewise, we'll have people that come in really worried because medications did nothing for me, and we're a bit nervous because we're like, oh gee, well maybe the surgery just works as well as it would for anyone else. Clearly, whatever hormones we needed to lean on weren't provided, in that particular medication, and so we're going to get to the point where we can be very precise about that. I'll be able to one day hopefully do a panel and say, right, well, look, you're going to get this much response from this medication. You're going to get this much response from surgery. Here's our options and this and that. And
we're again, talking more about that, the phenotyping, and that's kind of where I was going to bring in technology and how we're benefiting from AI and research and that sort of thing. And what I'm noticing in the events that I've been attending is how small the world is getting and how much research is being done, and now how we can actually pull all that together from different countries, and there's a lot more cohesion in groups that are specializing in this research, but they're able to bring it together now and give that and looking at kind of phenotypes for, like you're saying, oh, you've had this happen, you might be best with a bypass, and then later on you'll need this. And we'll be very good at predicting outcomes. We know the outcomes are good, kind of whatever we do with bariatric surgery, but it's like, then what? And patients are always a bit surprised later on when something does pop its head up. Again, looking at that ongoing need for lifelong care is, well, I've bubbled along nicely since I had my surgery, and now like something's happened and I'm starving. And it's like, well, now's the time to look at what's next. And now we kind of have what's next, which is great. Ways of ameliorating those kind of effects as well. And just keeping a check on things. But that's kind of with the with AI, I don't know what our limits are now with pooling data and discerning outcomes and predicting things. I don't know how it'll be compared to human understanding and clinical knowledge. What do you think?
Yeah, look,
I think foreign.
Yeah, there's so much going on. A lot can be done with data collection now very quickly and easily. It's a little bit hard because it's very easy to collect data for corporate reasons and to make money. There may be a few large companies around the world that do that very well.
Yes.
It is, in the field of healthcare and evidence-based care, obviously there's ethical principles that apply that don't apply if you're just doing this to make money, and that sort of makes it a bit harder in terms of what you do. Then, having said that, we're still going to see a lot of data collected. I'm working, one of the most exciting projects coming up, I'm working with a group called Impact Obesity. I'm going to trial an app that they've designed rather than the usual fitness tracker designed to, I don't know, sell products or maintain a subscription or that sort of stuff. This was designed by a charity with a group of obesity experts and mostly designed every step of the way by people with lived experience of obesity and treatment thereof. And so I'm excited about that. We're going to try we're going to trial it soon in our public center, and we're going to look at that at whether that is a pathway to having this approved by the TGA as a medical device. And at that point, that can be, if we can get that into the hands of enough people, that would be really, really cool in terms of the data that comes back from that. Something that's actually designed around the goals and needs of patients and their clinicians rather than designed to make money or sell stuff.
Yeah,
Would
I'm
be a
going to
rich
Google that.
source of data. So that's the Prospero app.
Yeah,
It's
that
it's
sounds
coming
brilliant.
soon in pipeline, that sort of thing. So that to me, those sorts of things are a really exciting opportunity.
Mm.
The next sort of data set that I'd love to see is, so we have the bariatric surgery registry.
Yes.
And it's been wonderful to show the safety and efficacy of bariatric surgery. They published some 5-year results.
Yeah.
Headline, yes, bariatric surgery is incredibly safe and effective in Australia, and the quality of it is extraordinary. The next thing though is to then, and we don't really have real world medication registries. So we don't really know what's happening to people in the real world on these medications. We've got lots of anecdotes, and I know what's happening to the people I meet, and you know what's happening to the people you meet, but we don't really know. And so I think some sort of, I don't know how we do this. I think Prospero will be able to do this a bit, but to look at, because they're looking at any form of treatment, whether then we can start getting that data set together. So for instance, we have cancer registries.
Yeah.
And so you don't need a particular type of treatment to go into a cancer registry where we can monitor results and the like. And it both is a source for research, but it's also a source for quality assurance. Yeah, and that's, I think, when it gets exciting. There's almost, in a lot of areas of medicine, there's almost this competitive thing. It's like, well, my length of stay is shorter than your length of stay, or and so that, I think, becomes cool, because then we can say, public hospitals should put 50% of people that meet them in with type 2 diabetes into remission, and which is, by the way, would be easily achievable if we adequately resource public hospitals and metabolic bariatric surgery. And you could actually watch that and say, well, hold on a second, the X hospital is only putting 5% of people with type 2 diabetes, new diagnosis of type 2 diabetes, into remission. What's wrong with that?
What's going on?
And that's just the diabetes example, but it'd be the same with everything. We really monitor outcomes and say, well, this is a fixable, treatable problem. Type 2 diabetes is a preventable and often reversible decompensated failure of the pancreas, in a degree of organ failure we wouldn't accept in any other discipline. So, and have those real conversations about, well, is your hospital doing the things it needs to do, not just for sort of individual patients, but also for health economics, because
the trajectory of that's expensive, isn't it?
Yeah. Well, and we talk about the burden of obesity, and it kind of pisses me off, because we're not talking about, oh, we're doing too many bypasses and too many sleeves, we're giving out too many medications. No, we're talking about the burden of neglect. We're talking about what happens when you don't treat the disease, the very predictable outcomes of people getting health, poor health outcome on top of poor health outcome, and requiring on a lot of healthcare resourcing to deal with that, rather than treating the upstream problem.
Where do you think that would start to stop treating the tail, actually treat the seat of this? Where do you think that would start as a health initiative for even a public health campaign? It's like, if you're seeing X, Y, and Z, like it's early stage, that would be the time, wouldn't it?
So I think there is no one answer to that, and it needs to be multifocal. And I think there's this idea now that we've got to find the thing. We've got to find the thing that's going to prevent, or the thing that's going to treat, and all this sort of stuff. And I'd point you towards skin cancer as an example in Australia. We are very good at making skin cancers, but we're also very, very good at preventing and treating them. We have slip, slop, slap. We have the majority of early skin cancer managed effectively by GPs in the community. And we have melanoma centers and cancer centers and the likes to deal with more complex disease.
Yeah.
And until we accept that that model works, and I can list a ton of other diseases where that radically transforms the
outcomes.
National Bowel Cancer Screening Program.
Yeah.
Right? risk assessment in general practice, gastroenterologists and surgeons everywhere doing the colonoscopies, and then cancer centres if polyps aren't knocked out on time. Time and time again, Australia leads the world because we have this multi-pronged approach. With that in mind, first practical thing, 40% of people in Australian public hospitals have obesity. We should you would hope that about 40% of public hospitals treated it. They don't.
Yeah.
So I think step one would be metabolic surgery. Really, like if it's laughable to me that you can still call yourself an upper GI surgeon and treat reflux, but not obesity. That's insane. Like hospitals that will let as many people come in the door and to be treated for reflux, but no one for obesity. Now, I love treating reflux. Come to me, I'll treat your reflux. I have no problem with that. What I do have a problem is working in a hospital that says this disease that responds better to medications than obesity does. This disease that is less likely to kill people than obesity is. This disease that overall, if we don't treat it, the cost to the consumer and the healthcare system is going to be low, versus if we don't treat obesity, the cost to the consumer and to the healthcare service is going to be very high. That's insane. So everywhere we treat reflux, we should also treat obesity. Simple as that. You don't get to do anti-reflux surgery without having anti-obesity surgery. And yes, there are smaller regional centres that may not be able to provide all of the services. If anyone listening is in one of those, you call me. We will happily organise a system where we can take the difficult cases off your hands, and you can do the safe, achievable, lower risk surgery in any reasonably resourced regional centre. Absolutely. One of the best services in Sydney by far, probably the most busiest service in Sydney is in New South Wales is in Wagga.
Yeah.
What can be achieved? This doesn't need to be an ivory centre big city game. That's the first thing. What you will automatically find is as soon as you do that, you have, at the Austin and in Wagga, and then you will automatically have a collection of people from other specialties that are interested in treating obesity, and the rest will come. The complex medical care and the wraparound care, because these hospitals already have dietitians and physiotherapists and occasionally exercise physiologists and all these sorts of things. Any cancer centre is going to have decent psychology services as well, all that sort of stuff. It's there. And it's sort of seen as this big, expensive step. It's not. The government rebates it or funds it just the same as any other type of surgery, along with outpatient and everything. And I think we really need to call out those hospitals that are just saying no based on sort of misplaced morality rather than biological reality, because they're squandering patients' lives and they're squandering healthcare money on band-aid solutions too late. That would be, those services would be better applied to people for whom obesity treatment would not prevent their disease. Yeah. So I think that's number one. That's something that I think we should all, and patients should, patients that can't get access to, please don't email me at the Austin. Email the CEO of your closest hospital and be like, what the hell is going on here? Why aren't you up to date? Why are you not doing this? Go and see your local MP. If you have to drive past a hospital to come and see me, fine. Now, I'm saying we shouldn't treat obesity in the private sector. We should, absolutely. Same as we do with hip replacement, same as we do with gallbladder, same as we do everything. But when less than 5% of Australian hospitals use the most effective treatment for the disease that kills the most Australians and the disease that causes the most liver disease, something's fundamentally wrong. And I think the rest will follow. And the reason I think the rest will follow is what I see around me. When you come and work with me and in a public service, and I think this is why being a public bariatric surgeon makes me a much better private bariatric surgeon, is I am constantly teaching, engaging with people, setting health-based rather than cosmetic-based goals, and doing that in such a way that I need to translate that to the administrators above me, as well as the people below me. I have mentors and mentees. Yes, you can keep in touch through private practice by showing up at conferences and reading journal articles and that sort of stuff. But I essentially have a conference a month. We sit down with 7 surgeons dedicated to this, and we discuss cases that we've seen. I get to get experience once in a lifetime cases kind of all the time between the mix of people that we have. And then, we're writing guidelines, all that sort of stuff. And then everyone that comes through that healthcare system, where do we train? All of our junior doctors, all of our dietitians, and so they get to see what real obesity treatment looks like. And I think then it just flows from there. And the problem we have is that at the moment in most hospitals, in my hospital, you get to see what good obesity treatment looks like before you become a consultant. But in most of the hospitals in Australia, that's just not the case. They have no concept. They don't get to see it. Yes, they get to read that there's this thing called metabolic and bariatric surgery.
Yeah, but you have to kind of specialize to understand it, don't you?
Yeah.
All the adjunct courses and that sort of thing. And it has to be kind of an area of special interest before it's understood and it's common knowledge of how to look after these patients, for sure.
And so, and as I trained, I've never done open heart surgery. I've assisted a couple, but I know what open heart surgery is because I've seen, as through my training, I've seen that, I've dealt with that, I've seen that happen. I know that thing. Same with orthopedics and all the areas I don't specialize in, I get exposure to that as I go through. And it makes me that much better at doing that. I know who to send to an orthopedic surgeon because I understand the ins and outs of enough to understand. And that's what we're completely missing here. So I think that's first and foremost, I think that's huge. It'll all spread down from that. We just need to treat where we train. And I think the rest will follow on. And I think, and likewise, I think, a call out to my colleagues, it's really time to step up. If someone said to you, no, we're a public hospital, we don't want you to treat cancer, you'd go to the newspaper.
Yeah, just be a no-brainer.
It's not okay for you to operate in private with a public appointment and treat one disease in one place and one disease on the other. And it's not okay for you to teach the next generation and leave out Australia's most important disease.
What an advocate you are. And I think there's so much in that, isn't there? And coming to the Future of Obesity and Metabolic Health Conference would be in everyone's benefit, patients or practitioners, because it's a voice, it's an opportunity to have a voice and just spread the word about. I think we're just, treating the symptoms when we're looking at heart disease or the focus we put on different treatments. Cancer is also an offshoot of obesity in a lot of situations. So it's like these end stages are being treated before the actual cause. So let's hope for some change in that trajectory.
It's happening. It's and I think that's the most exciting thing, and that's why really cool is that I hear GPs are just not comfortable with not being able to refer people for the things they know they need anymore. Patients are in more and more circumstances feeling empowered to say, no, this is not okay that I get turned away with bad advice. I need something meaningful to treat this. I think that, in healthcare services and political services, we're often now at least getting into rooms that we didn't, and having conversations we could never have before. So I think there's a real groundswell here that I'm excited about. Where the advocacy stuff. I'm watch this space. I'm working with the group to look to push very hard towards.
I know the Austin's a huge part of that too, which is fantastic.
Yeah, oh man, I'm so lucky. I coax along with it with a whole lot of really good people, just enabling me to have impacts that otherwise it would not be impossible. So it would be entirely impossible. So it's really, really cool. Both all the places where I am. So that's cool. But so we're going to push from within. We're going to try and get people to push from without. But hopefully we can drive some sustainable positive change.
Yeah, well done. Thank you. And I will definitely be seeing you on the 5th of June this year at Park Royal. It's at the Park Royal, Darling Harbour, Sydney, Australia. So it runs for a couple of days and open to the public. We have a special discount for our listeners to attend the Future of Obesity and Metabolic Health Conference. So please refer to the show notes on the Australian Weight Loss Surgery podcast.com. And you'll be able to find the code there. Alex Craven is a huge part of the Austin Hospital, also private practice. How would we find you, Alex, if we've got questions or want to have a chat?
I'm around if you want to see me doing silly videos, Dr. Alex Craven,
I
on
watch you walking
Instagram
to
and
work. Is that
Facebook.
you walking to work in the mornings when you're
Often,
doing your,
yes.
yeah,
Yes, panting a little bit out of breath, trying to
it's
say
good.
pithy quotes about obesity, but just
Yeah, it's
showing that I
good.
should do more cardio. Yeah. dralexcraven.com. Darabin Weight Loss Surgery is where I work privately, and of course, austin.org.au is the Austin, where I'm pretty findable if you want to find
Flying
me.
the
So
flag. Yeah, I
reach
have
out and
one of the
engage.
one patient story I did on the podcast with Francis Olson, and I know he's been lucky enough to be a part of that must be the trial, and he's every now and then he sends me a message on Facebook and says, "Look what I'm doing, look what I've got," and it's I would love to have documented what you're doing there, from that kind of integrative health perspective, and looking at kind of what he's been offered as part of the program. It's really significant, and I know he's just absolutely changing his life. And again, I just tear up because he contacts me. He's like, "Look what I just did, and here's the map of my strata." And like you say, it's pretty organic that the movement comes with it. But I just think he has been stuck for so long, and there's a whole lot of different mixes that come with that, and just to see him succeed, I just love it. Yeah, so
Yeah,
it's
it's that clinical. I can tell you, I get into some pretty frustrating conversations and get pretty down about lack of access and people that I think have sort of been neglected and or offered poor options, or even been offered the right option with a poor explanation and all the rest of it. And it can really get you down. But I tell you, that clinical stuff just keeps you so grounded. Like
oh, yeah.
just there's I enjoy all of medicine. Everything I've done has been great, and it's because of that. It's when you just get to make that contribution, or
Difference.
even watch others make that contribution. Like even things like a situation with eating disorders. If I can facilitate someone engaging with a good mental health team around that, and just watching them come back, and the shoulders of just
Yeah,
a different, all those sorts of things. I don't even need to be the cause of it. It's just watching
just to
really good
see.
things
Yeah,
happen. And and it's the cancer work, the general surgery work, it's all the same, and obesity is just the same. If you get to be in a team that treats a disease well, it's just wonderful.
yeah. Congratulations, and catch you in June.
Yeah, see you
And
there. It'd be
I'll
good.
be I'll be moderating. Thank you so much for your time. I really appreciate it.
Pleasure.
And
Yeah.
I'm sure we could cover a whole nother lot of topics. Now I've got you.
Oh, yeah. Very happy to do it again. We'll talk about something else. There's always something new to
Thanks.
talk about.